What are the diagnostic goals for ovarian masses? It's important to discriminate between lesions that need to be further evaluated with imaging, a follow-up, have surgery, and those that do not. Determine if the MRI, CT exam, or a follow-up ultrasound should be done for management decisions. If you do think that it's suspicious for a malignancy, then you may want to refer the patient to a gynecological oncologist. It's important to be able to determine if the mass that you're seeing is ovarian or extra-ovarian. Look for a rim of ovarian parenchyma, little follicles surrounding the mass, to establish an intra-ovarian origin. Identify a separate ipsilateral ovary from the mass to establish that it's extra-ovarian in origin. While scanning, observe movement of the mass with respect to the ovary during manual compression or with a transducer. Here is a ovarian cystic mass, and we see in the periphery a few little follicles to confirm that it's within the ovary. And nicely you can see here high resistant waveform in this proliferative phase. Another case of ovarian cyst, and you can see nicely that this the cyst is surrounded by ovarian tissue, longitudinal, transverse. So you can see nicely the ovarian tissue, and you see in the periphery it's a low resistant waveform, probably due to the luteal phase of the cycle. In premenopausal women who present with large ovarian cysts, greater than 5 centimeters, we perform transvaginal guided transvaginal cyst aspiration. We use a transvaginal probe with a guide and insert a 20 gauge, 20 centimeter needle through the vaginal vault into the cyst, aspirating the fluid. Patients usually get immediate relief from the pain. The procedure is not painful. Occasionally I will place a little lidocaine in the vaginal vault, but if there's no inflammation, there's probably no need for lidocaine. Another cause of pain due to ovarian origin is pelvic inflammatory disease. Usually these ovaries are enlarged. They have decreased cortical medullary differentiation. The masses, when they do present as a mass, which are seen in 38.9% of the cases, they're usually nonspecific. Masses are probably most likely due to tubal ovarian abscess, and these can be cystic, complex, or solid. Sometimes these masses represent adhesions of the ovaries to the omentum, and occasionally identification of gas can be seen and confirms the diagnosis. Here's a beautiful Netter diagram showing fallopian tube and infection going into the ovary. Actually, the ovary is pretty resistant to infection, and first sign you will see is endometriitis. Then you will see, since it's an ascending infection, the infection starts from the cervix up the endometrium into the fallopian tubes, and usually the ovaries are the last to be affected, and they're pretty resistant, as you can see here. But after continuous spillage of purulent fluid into the perioovarian region, the ovary does get infected, and you can see nicely on this transvaginal study, which correlates nicely with the Netter diagram, the dilated fallopian tube with complex or heterogeneous fluid within it and penetrating into the ovary, infecting the ovary. In this case, we refer this to a tubal ovarian complex and not quite a tubal ovarian abscess, instead of a tubal ovarian abscess, which we see in this case. In this case, transabdominal on your left and transvaginal on the right, we see posterior to the uterus a complex mass. Seen better on the delineated much better on this transvaginal study. We see a solid material within the mass. And this was a tubal ovarian abscess, which can be drained. And here's another patient, bilateral disease, which is common in pelvic inflammatory disease. This is a transabdominal transverse views of the uterus and shows bilateral adnexal masses. Transvaginal ultrasound on your right shows that the masses are very complex, multiloculated. In this case, there was nothing to actually drain. This patient was treated with antibiotic treatment, and after antibiotic therapy, she returned and her ovaries had resumed the normal size and morphology. Tube ovarian abscess. When tube ovarian abscesses are refractory to medical management, that means antibiotic treatment, they can be drained with ultrasound guidance, either using transabdominal, transvaginal, or transrectal approach. The approach really depends on the location of the abscess. An abscess high in the pelvis or anterior to the uterus, you may want to do a transabdominal approach. In those abscesses in the cul-de-sac, you may want to do a transvaginal or transrectal approach. Ultrasound-guided aspiration is very effective and safe and avoids laparoscopic and laparotomy. Transvaginal guided technique eliminates the risk of general anesthesia, surgical morbidity, and abdominal wall complications. It also avoids the loops of bowel, urinary bladder, uterus, neurovascular structure, therefore makes this procedure much more desirable. Systemic antibiotics should be administered when this procedure is done. Occasionally, if you get non-purulent collection, you may just want to do an aspiration without placement of the catheter. If you do obtain purulent fluid when you do aspirate these fluid collections, you may want to place a catheter for at least 3 days, irrigating it every day with saline. The curative rate is about 78%, even in these patients with purulent fluid. And here's a case. A patient presented with a large complex mass, and we drained it using transvaginal guided transvaginal aspiration. And as you can see here on the right, we didn't completely, and usually you don't completely drain it completely, but enough that you can start treating the patient with antibiotics. Here's another patient. This was a difficult case. It was difficult to see this abscess. We actually had seen it on CT, and then when we did the transvaginal ultrasound, this correlated with what we had seen on CT. And these echogenic areas within this solid-looking mass was gas. And you can see here the needle coming in and draining this purulent fluid collection. Postmenopausal women can also get tube ovarian abscess. It's a rare condition. It's only seen in 1.7% of all the tube ovarian abscess. Usually these women require surgery, and the diagnosis is not made preoperatively. And the cause of this is recurrent pelvic inflammatory disease. The responsible agent is usually E. coli or Klebsiella. These patients require prolonged hospitalization and do get complications. So it's important in the postmenopausal woman, if you suspect a tube ovarian abscess, to do early and radical surgery.